Today I am going to speak on managing cerebral palsy. We all are aware CP is a vast topic and a lot of research is happening. There are a lot of technological advances. The concepts in the CP are evolving with respect to terminologies, definitions, management methods, management protocols. A lot of importance is being given to adults with cerebral palsy now. So in the time allotted, it is not possible to cover all these aspects of CP. So I tried to present a brief overview of all the important issues related to CP. To begin with, we all know CP is an umbrella term for a collection of conditions resulting in lifelong motor disability. Together they constitute the most common cause of physical impairment in children and are responsible for permanent activity limitation and lifetime participation restriction. Children and adults included under the umbrellas under the CP umbrella have a very heterogeneous clinical presentations. The overall worldwide birth prevalence of CP is around 2.1 to 2.9 per 1,000 live births, but this can vary significantly by region, with higher rates being observed in low and middle income countries compared to the high income countries. When I was a resident, we had many definitions of cerebral palsy. Each specialty textbook had its own definitions. So what we were taught was there are four important components of any definition of CP. One is a disorder of movement and posture, results from an abnormality in brain acquired early in life, and the brain lesion is static. But in 2004, an attempt was made to come out with a universal definition where all the specialties mutually agreed, and this definition came out in 2006, which defined CP as a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occur in the developing fetal and infant brain. The motor disorders of CP are often accompanied by disturbances of sensation, perception, cognition, communication and behavior, and by epilepsy and by secondary musculoskeletal problems. So this definition tried to look at all aspects of CP. Of course, this was not perfect or ideal. It had its own lacunae. Review was being done, and just few months ago, the same group came up with an updated description of CP. Now they have defined CP as an early onset lifelong neurodevelopmental condition characterized by limitations in activity due to impaired development of movement and posture, manifesting as spasticity, dystonia, choreoathetosis and or ataxia. It results from maldevelopment attributed to dysplasia of or injury to the fetal or infant brain that is not degenerative, although the manifestations may change with age. The phenotype of CP is complex and heterogeneous, with each person experiencing a unique presentation. In addition to motor dysfunction, people with CP frequently encounter primary and secondary impairments across various areas of development and functioning, which can significantly impact their participation in active life. Now coming to risk factors of CP, we all know the risk factors can be grouped into three: the prenatal, perinatal and postnatal. 70 to 80% of the causes are because of the prenatal and 10% of the causes are because of perinatal. Classification of CP, we can classify CP in various ways. The most commonly used conventional method of classifying CP is based on the tone. We have the spastic CP, which is the most common. 80% of the CP cases are spastic. Then we have dyskinetic CP, which accounts for the remaining 20% of the cases. Again, dyskinetic CP can be atheratoid, coriform, dystonic or ataxic. Hypotonic, which is very rare, and then we have mixed. Many centers in India are now saying that the most common type of CP they see is not the spastic one, it is mixed one, where we see spasticity and element of dystonia. The other conventional classification which we have is the topographical classification, where we have hemiplegia, which is unilateral upper and lower limb involvement. Then we have diplegia, which is major involvement of both the lower limbs with minimal or minor involvement of both the upper limbs. Triplegia, also known as three-limb dominant bilateral spastic, where we have involvement of both the lower limbs with one upper limb. Quadriplegia, which is also known as total body involvement, which is involvement of all four limbs with trunk and oropharynx. Monoplegia, which is very rare. They say it's involvement of one limb only, but usually they say it's a case of hemiplegia where one limb is minimally involved. One more classification now which is being very commonly used is the one which is given by the surveillance of CP in Europe. This divides CP into spastic, Again, the spastic, depending upon the involvement, can be spastic bilateral and spastic unilateral. So what this classification has done is, they have labeled quadriplegics, diplegics and triplegics into one group, that is spastic bilateral, and then we have spastic unilateral. Then if the tone is varying, it can be dyskinetic CP. Again, the dyskinetic CP can be dystonic CP or choreothetic CP. Again, if the tone is hypotonic with ataxia, they have labeled it as ataxic CP. So this classification is now very commonly being used. Again, there are functional classification systems. There are many classification systems, but the four commonly used to assess mobility, to assess hand functions, communication and eating and disability are the GMFCS. We all know the gross motor function classification system. For upper limb assessment, we have the manual ability classification system. For communication disorders, we have the communication function classification system. And for eating and drinking, we have the eating and drinking ability classification system. All these scales rate the child from 1 to 5. They help us to know the severity of the functional impairments and also help us in explaining the prognosis to the parents. Now coming to diagnosis, CP is usually a clinical diagnosis. Most of the cases we can diagnose clinically without any investigations by a careful history and detailed clinical examination. Although neuroimaging is not a prerequisite for the diagnosis of CP, neuroimaging findings are abnormal in more than 80% of the cases with CP. MRI is the investigation of choice for neuroimaging. Cranial ultrasound and CT scan, although inferior in soft tissue resolution, have a potential role in diagnosis and management. The MRI findings in CP, the most common MRI finding in CP is the periventricular leukomalacia, which is seen in 42.5% of the cases, followed by basal ganglia lesions, cortical and subcortical lesions, malformations, focal infarcts and miscellaneous lesions. In this study, normal MRI is seen in 11.7% of the cases, but if you see the other papers, even CP cases might have normal MRI in 10 to 15% of the cases. MRI in CP does not dwell only in the diagnosis or revealing the pathology. There are enough studies to say that MRI findings have a strong correlation with clinical findings also. For example, white matter damage of prematurity like preventricular leukomalacia is seen in around 71.3% of the cases with diplegia, 34.1 cases of hemiplegia and 35.1 cases of quadriplegia. So it can be seen in any type of CP. Children with spastic quadriplegia tend to have extensive damage across all areas of the brain, and these cases are usually non-ambulatory and have severe cognitive impairments. The basal ganglia and thalamic damage is usually seen in dystonic type of CP, but occasionally can be seen in spastic quadriplegia as well. Focal cortical infarcts are almost exclusively related to, exclusively seen in hemiplegic CP. Now differential diagnosis. Nowadays we use a lot of terms called CP mimics, atypical CP or CP masqueraders. What are these? These terms share common elements, that is a lack of documented risk factors or neuroimaging results consistent with a history of brain injury. Why these are important? Because some of these are treatable. It helps in prognostication, genetic counseling and prenatal testing. In a systematic review, it was found that at least 54 treatable inborn errors of metabolism mimic CP. So the idea is we should not miss these cases, because if we are able to diagnose a treatable cause, we can cure the child of his or her signs and symptoms. How do you pick up this? There are certain red flags in the history, clinical examination or MRI findings. If you are able to pick up these things, then these children have to be followed up in a separate way. There are algorithms how to manage these cases. Coming to clinical evaluation, the goals of clinical evaluation is to differentiate CP from progressive causes of neuromotor disability and spinal lesions, to define the musculoskeletal impairment and decide on ways of treatment, to identify, evaluate and address the accompanying impairments. This requires a detailed history with regards to mother, pregnancy, delivery and child, a recording of the developmental milestones and a detailed neuromusculoskeletal examination. So we don't focus only on the CNS examination or the musculoskeletal. This requires a detailed neuromusculoskeletal examination. Now clinical examination, the main area is assessment of muscle tone, determination of strength, examination of selective motor control of specific muscle groups, estimation of static deformity and or muscle contracture at each joint, evaluation of posture, balance and equilibrium responses in standing position, gait analysis. The workup may also include for testing other associated conditions and complications which are commonly seen in CP, like intellectual disability, epilepsy, speech and language disorders, vision defects and hearing impairments, because even they have a say in the management protocols. Coming to assessment of spasticity, two scales are commonly used, the modified Ashworth scale and the modified Tardieu scale. Modified Ashworth scale, I'm sure we all use in our OPD, which is 0, 1, 1 plus 2, 3, 4. Modified Tardieu scale. Modified Tardieu scale is very important when we are considering injection botulinum toxin for managing spasticity. We have two values, R1 and R2, because we all know botulinum toxin helps only in dynamic spasticity. It does not help when there is a contracture. So larger is the difference between R1 and R2, it indicates dynamic spasticity, and smaller the difference, it indicates there is a presence of contracture. This is how we get two values, R1 and R2 on in Tardieu scale. Then for selective motor control, we use a standard classification which is Grade 0, 1 and 2. Grade 0 is no ability or only patterned movement is observed. Grade 1 is partial ability or partially isolated movements. Grade 2 is complete ability or completely isolated movements. For strength, we use the standard MRC scale. I am not going to go into individual joints because of the paucity of time, but some tests are very important. For example, an ankle silver skull test is important. In the knee, calculating the right popliteal angle is important. In the hips, we have the Thomas test, we have the Duncan alley test. So all these tests are very important when you are assessing a child with cerebral palsy. Next is gait. If the child is ambulatory, we need to examine the gait. For hemiplegia, we use a standard classification given by Winters, Gage and Hicks, where we have 4 types of gait. Group 1 is drop foot because of the weak dorsiflexors. Second is true equinus. Third is equinus with jump knee. And the fourth is 3 plus hips are in flexion, adduction and internal rotation. In all these 4 groups, the highest risk of hip displacement is seen in group 4 because the hips are in flexion, adduction and internal rotation. Usually in hemiplegics, it is very easy to label the child into any one of these gait patterns. Similarly, for diplegics, we have the classification given to us by Rhoda and Graham, which again has 4 types of gait: true equinus, jump gait, apparent equinus and crouch gait. In diplegics, they say it is little bit difficult to label the child into one of these gait patterns. So there are some schools of thought which do not agree with this. But the idea behind observing the gait and trying to define the gait is because you have detailed management algorithms. If you are able to know what type of gait it is and what is the age of the child, detailed algorithms are available how to manage the child, what interventions are best and what interventions we should not be doing. This is one more diplegic gait pattern suggested by Freeman Miller, which says that usually a child with spastic diplegia starts walking on the tiptoes with knees in flexion and the hips are internally rotated. If neglected, it goes to crouch gait, and again if not managed appropriately, the child lands up on a wheelchair. Now for me, when the child comes to me for the first time, the examination is not complete unless until I examine the hips and the spine. Irrespective of age of the child and what type of CP the child is having, hips and spine examination is very, very important. Why hips are so important? It is assumed that every CP patient has an abnormal hip unless proved otherwise. It is second only to equinus deformity. The prevalence of hip subluxation is around 35% for the entire CP population. It is silent and progressive. Pain is seen in more than 50% of the patients. It is difficult to detect but easy to manage if picked up early. It is easy to detect but difficult to manage in the later stages. So if you see the natural history of this spastic hip disease, the hips are located at birth. So hips are normal at birth. The displacement occurs at the rate of 4 to 8% per year. Easily missed on clinical examination, easily detected on X-ray, can be easily monitored on sequential X-rays. I am sure many of us have seen this diagram. There is a direct correlation between GMFCS levels and hip displacement. In GMFCS levels, the incidence is hardly 10%, but it can be high as 90% in GMFCS 5. Now, how we calculate the hip displacement? Simple X-ray pelvis with both hips AP view is required. We use something called Reimer's migration index or migration percentage. It represents that portion of the ossified femoral head which has migrated laterally beyond the Perkins line. On a simple X-ray, this is how we draw the lines and calculate the migration percentage. The cutoff percentage is 30%. Hips presenting with a migration percentage of more than 30% are considered to be displaced. I agree, in today's time, taking X-ray, drawing all these lines is tedious. So we have apps available both for Android phones and the Apple phones, where we can download the app. If you have a digital X-ray, rulers are there. We can calculate the migration percentage very easily, and they're fairly accurate. Again, hip surveillance, we have the own Indian hip surveillance guidelines. We don't have to, unlike before, we don't have to depend on other guidelines. These were released in 2022. These guidelines were framed by taking all the specialties which have a say in CP management, including PMR, when these guidelines were formed. So these guidelines have been endorsed by IPMR. These are free to use, easy to use, and any of you can download the guidelines on the website of Pediatric Orthopedic Society of India. If you see, two things are important in these guidelines: the clinical examination and X-ray, pelvis with both hips. The frequency depends upon the GMSS levels. If you see the common thing, all the childs enter this surveillance program at the age of 2 years. So the first clinical examination, the first X-ray is done at the age of 2 years, and then the frequency depends upon the. Now coming to management of CP, as no cure is available for CP, ultimate goal of CP management is minimizing disability while promoting independence and full participation in society. All treatment efforts are directed to gain independence in activities of daily living, ability to go to school, earn a living, and have a social life. The treatment is based on a realistic evaluation of child's present functional status and possible future prognosis. The main components of CP rehab are improving mobility, preventing deformity, helping the child to learn the skills he or she needs in daily life, and educating the parents about the child's problem. Recently, I read these goals in a textbook which I feel are very apt. The first aspect of treating a child with CP is ensuring that the families have heard and come to some level of acceptance that the child has a problem called CP, which is permanent and will not go away. This is very important. I feel in our scenario, this is difficult because most of these parents, most of the families come from the lower socioeconomic status. This will take time, but this is very, very important. We should help these children and families cope with the disability and allow individuals with CP to function at their maximum ability. However, we must also recognize that too much focus on perfection of function may cause damage to the growth and development of the child and family unit, especially in the social, psychological, and educational domains. I think this is also very apt because at times we try to overdo things to gain perfection or whatever. We want the child to become normal. Sometimes it is not practically possible. Always in the context of this final goal, we as physicians want the individual's physical impairments minimized as much as technically possible. Again, we all know CP management is a multidisciplinary team. Again, the most important member in this team is the patient and the patient's family or the caregivers. Now, before we go into the management, this is a very good paper which I quote very commonly. This was published in 2019. After filtering out various articles, they reviewed around 250 articles covering all aspects of CP management. And they gave this beautiful diagram, beautiful picture. If you see, this is the worth line. Anything below the worth line is not beneficial. Above the worth line, the things which are mentioned in yellow probably help, and the things which are in green definitely help. They have covered various management methods, therapies, early intervention for tone antispastic medications, botulinum toxin, serial casting, and again surgeries for contracture and alignment. Now, as spastic CP is the most common CP, how do you manage spasticity? We have non-pharmacological management, pharmacological management, which includes oral medications, injectables, and intrathecal medications, and the surgical management. Non-pharmacological management, we all know prevention of noxious stimuli, patient education, proper positioning, therapeutic exercises, physical modalities, biofeedback, and orthosis. Coming to oral medications, we have very few choices. The most commonly used medicine is baclofen, diazepam. Dantrolene is not available in India, tizanidine, clonidine. Nowadays, many centers are using gabapentin. Usually, the preferred drug is baclofen. Sometimes we use a combination of baclofen and diazepam. The most important thing to remember is we start all these medicines in low doses, and then we titrate the dose every 5 to 7 days depending upon the response. As I said, in some centers, including in my institute, the most common type of CPVC is a combination of spasticity and dystonia. So the most common medicine we use for dystonia is trihexyphenolyl, THP. The added advantage is, suppose as a child, most of the CP quadriplegic cases complain of excessive drooling of saliva. So THP will not only help in reducing the dystonic movements, it also helps in reducing the drooling of saliva. So there is a dual advantage of using THP in those cases. Coming to injectables, we have the aqueous phenol, 2 to 6% in water or saline. Very few centers use it as of today. And neurotoxins, botulinum toxin, which is very commonly used. This is how we inject phenol using a nerve locator into the motor point of the nerve, and this is the way we use botulinum toxin. When I was a resident and I was attending a workshop on botulinum toxin, one of the faculties in that workshop was Dr. Ashok Johari sir, who is a renowned pediatric orthopedic surgeon. So I still remember his words. He had said that the skill is not giving the Botox injection or botulinum toxin injection, because that time we have only had Botox. We didn't have all these other companies which are there in India now. So he said anybody who can give IM injection can give injection botulinum toxin. The skill lies in choosing the right patient, the right muscle and the right dose. If you want successful functional outcomes, you have to choose the right patient, the right muscle and the right dose. Otherwise, it will be a failure. So I try to still follow these. Again, Botox injection can be given using the surface anatomy or ultrasound guided as per the convenience. Intrathecal medications, we have the intrathecal baclofen pump, which is hugely popular not in India but in some European countries and America, especially for cases of GMFCS 4 and 5 who require very high levels of oral baclofen. It allows delivery of baclofen directly into CSF so that higher effective doses can be attained at the receptor sites in spinal cord than with oral administration. The typical intrathecal dose of baclofen is only 0.3 to 0.5% of the oral dose. It is administered by a pump which is implanted subcutaneously in the abdominal wall with a catheter surgically placed in the subarachnoid space. Usually this pump battery lasts for 4 to 5 years, so the pump has to be replaced every 4 to 5 years. This is how the pump looks like. When I speak of intrathecal baclofen pump, the picture comes, if you see the images on my right, CP child. When I was a PG in AIIPMR Mumbai, I mean the use of these pumps, but these pumps for management of spasticity were just introduced. So thanks to our then director Dr. Athani sir, who wanted to experience and teach us about these pumps, he procured 2 pumps. And we collaborated with other experts because we never had the experience of managing or implanting these pumps. Dr. Lakshmi was a pain physician who collaborated with us. The first pump was implanted into an adult patient. I still remember he was a spastic paraplegia because of port spine. He was having severe spasticity, pain because of spasticity, flexor spasms. He was on a wheelchair. And after implanting the pump, his spasticity drastically came down, the pain went away, and the flexor spasms reduced, and he started walking with a walker. Seeing the functional results, they decided to implant the second pump in the CP quadriplegic child who was around 15 years old, GMFCS 5, who was wheelchair dependent, and everything went well in the beginning. Good reduction in spasticity, but after a couple of weeks, we had a keloid formation on the scar, and the scar just gave away, and the pump came out. Everybody was stunned because this was not a usual complication expected. He was immediately taken into OT, discussed with other experts, and the pump was re-implanted. Again, after a couple of weeks, the same thing happened. Again, the scar gave way and the pump came out. Again, after discussing with other experts from Mumbai, outside Mumbai, and some immunologists also, because we were thinking this is something maybe to do with foreign body reaction or something of that sort, it was decided to implant the pump on the other side. But again, the other side, the same thing happened. So eventually, after seeing the suffering of the child, the parents, it was eventually decided to just remove the pump and to switch back to conservative management, which was going on before. This was an unusual case of intrathecal baclofen pump, which was presented in an international conference by Dr. Lakshmi Vas. Now coming to surgical management, we have central surgeries and we have peripheral surgeries. Central surgeries, we have selective posterior rhizotomy, which is not our domain. What we do is the peripheral surgeries, the upper and lower limb surgeries. If you see the earlier concepts, it was multi-stage surgery. That's the reason why Dr. Mercer Rang referred to CP as a Bergdorf syndrome, because every time one joint is operated. Usually we used to operate first the ankle, then the knee, then the hips. The disadvantages are repeated surgical interventions which require multiple hospital admissions and rehab programs, recurrence or overcorrection, risk of deformity spread to adjacent joints or skeleton during the waiting time. Sometimes ambulatory children become non-ambulatory. So this is no longer followed now. So what is the current concept? The current concept is something like single event multi-level surgery, which is the recommended and preferred method for managing cerebral palsy now. It was first described in 1985. It is defined as correction of soft tissue or bony deformities at a minimum of 2 anatomical levels during a single operative event. So you have to operate at least 2 joints in the single event. Now this is one more stage just to indicate the need for surgery. If you see in stage 1, earlier stages, it is only pure spasticity. So they say you should go for therapy, medications, botulinum toxin. Surgeries is not required. In stage 2, there is the musculotendinous contractures where you can go for soft tissue surgeries, and stage 3 is a stage where you have bony deformities. So along with soft tissue surgeries, you have to go for rotational osteotomies and joint stabilization. So the most important thing comes is what's the best time to operate the CP child. There we have many papers now. So this is the most commonly accepted algorithm that the best time to operate the CP child is between 6 to 12 years of age. They say before 6 years of age, you should not operate the CP child. The only surgery indicated before 6 years of age is the hip surgery for hip subluxation or displacement. No other surgery should be done before 6 years of age. They say you can use botulinum toxin, phenol nerve blocks, orthosis, whatever you want to, but delay the surgery till 6 years of age. Now I don't do bony surgery, so I'll just show you some slides of the soft tissue surgeries which I commonly do. For hip adduction deformity or scissoring, we do something called adductor tenotomy. One more procedure is anterior division of obturator neurectomy, which is given in all textbooks. I personally have not done this, and I have not seen anybody doing this also, because it just cuts off all the adductors, hip adductors. Hip flexion deformity, we commonly do the iliopsoas stenotomy or the straight head rectus release. For knee flexion deformity, previous concept was do fractional lengthening of both the hamstrings, medial and lateral, but now the concept is do only medial side. In fact, last 5 or 6 years, I have not done both the sides, because previously even my 2 cases have got genuine recurrectum deformity post-operatively. So now the concept is you do only on the medial side, you don't touch the lateral side, and last 5 or 6 years I have been doing only on the medial side. I don't open up the lateral side. We get a decent correction, and there are no post-op deformities like genorecurrectum. For equinus deformity, we do tendo-Achilles lengthening. Again, various procedures there. But nowadays, if you see, there are so many papers which say that you should not do tail lengthening. In fact, according to most of the papers now, tail lengthening does more harm than good. But unlike before, I do it in very selective cases now, and fortunately, I do in very selective hemiplegic cases. The results have been very good. I mean, I have a follow-up of patients. I think the longest follow-up I have is around 10 to 12 years of age. A hemiplegic girl who's going to college now, I had operated around 10 to 12 years of age. There is no recurrence of deformity, no any other deformity also. So I have quite a few cases, but I do tail lengthening in very selected cases now compared to before, where it was very commonly done for all cases. Coming to deformities in upper limb, typical hemiplegic hand, the indications for doing upper limb spastic surgeries are very less. It's usually a hemiplegic hand. In shoulder, we have the adduction and interrotation. In elbow, we have the flexion. Forearm, we have pronation. Wrist, we have flexion and ulnar deviation. Fingers, we have thumb and palm deformity. Again, the indications are very less. A thorough assessment is required. Again, we try to do a single event multi-level surgery. We don't focus only on one thing. For elbow flexion deformity, we do biceps lengthening with or without brachialis lengthening. For forearm pronation deformity, we do the pronator release. For wrist flexion deformity, usually we do fractional lengthening of the long flexors. Then along with it, we do something called Green's transfer, which is flexor carpi ulnaris to ECRB. And then for the thumb and palm deformity, we do the adductor release. Usually we combine these surgeries. Usually we combine adductor release, Green's transfer, and fractional lengthening of the long flexors. Now lastly, we have 2 important events with regards to CP awareness next week. One is the National CP Day, which is celebrated on 3rd of October every year to honor the services of Dr. Mullah Feroz, who was the founder president of Indian Academy of Cerebral Palsy and also pioneered multidisciplinary CP care in India. Also, we have the World CP Day on 6th of October every year, and this year the theme is #Unique and United.
Sir, I would like to know about the medial hamstring release procedure. So you said that previously you used to do both medial and lateral hamstring release.
Yeah.
So now you are just doing medial hamstring release. Sir, what is the difference in the post-op rehabilitation program, sir, now that you are doing only one side?
The rehab protocol is the same. I mean, usually what I do is I put a Aboni cast. The most important thing, what they say is on the table, you should not overcorrect it. Always 10 to 15 degrees of knee flexion has to be there. If you try to overcorrect it and gain full correction on the table, then there are very high chances that the child is going to get genu recurvatum. So the dictum is, on the table while putting the cast, you never overcorrect the knee. Always when you put the Aboni cast also, we maintain the knee flexion of 10 to 15 degrees. So usually we put the Aboni cast. It depends whether you have operated the ankle or no. We put the Aboni cast and then you do suture removal at 2 weeks by making a small window, and we keep the leg in the cast for 6 weeks. The post-op regimen remains the same. Only thing what they say is, if you do lateral hamstring lengthening of the lateral side also, the chances of child getting genu recurvatum are very high. That's the only reason why they say go only for medial, because if you see, practically even I have experienced, managing genu recurvatum is more difficult than managing knee flexion deformity.
Sir, one more, sir. The amount of correction that you're saying, like in how many, like 10 degrees, in how many weeks, like you're correcting that?
I'm sorry?
Like I want to know the like exact duration, like in 1 week, like how much correction you have to do. Like, for example, if the patient has 90%, 90 degrees, so 90 degrees ROM restriction, then if you are correcting the ROM, like how much you are correcting in a week? Is there any program?
Correcting one time in the surgery. If suppose the popliteal angle is 90 degrees, we operate all these patients in the supine position. That's the reason why we can see how much correction we have got. Again, we do semitendinosus and semimembranosus. The amount of lengthening we do, it all depends on what is the pre or popliteal angle. We bring the popliteal angle from 80 or 90 degrees to only 10 degrees, and then we stop there. We close it and we put the cast in 10 to 15 degrees of knee flexion.
We have all major 3 topics covered here as far as long cases are concerned, like a stroke, a spinal cord injury and CP, that you are likely to get in your this MD examination. And apart from that, while you are having this CP child examine, how many of you are having IPD at your setup, if I can ask? IPD at your setup or your institute? Okay, not all of them. So even if you are assessing an IPD during ward round, what I am trying to suggest or request you, you always try to touch the child, not during the ward round just see the child sleeping on the bed or sleeping on the couch. You just try to touch the child, hold it with your hand and try to keep it just above the bed and see what he is doing. Like we in our ward round, we always tell our resident, observe the child. Like someone is talking and child is rotating his head towards him or her. That means his ears is functioning very well and head balance and this neck balance is very good. Again, if child is trying to catch something, that means he has some coordinating activity with him. And again the child is responding. That means child is interacting with the ecosystem and environment and interacting with the surroundings. That is very important observation you can make in a single observation. So not only observe the child as the American guidelines are suggesting here, observe the child as the child is in front of your eyes. Observe everything. And again, these kind of children have many birthdays. Like when the child has got his sitting balance, when the child has got his neck holding, when the child has got his tongue control. Every day need to be celebrated and patient need to be counseled in that way.
I would like to add that serial casting is also a method of conservative management. And in places where you cannot do surgery, you can do serial casting, and if the the parents are not agreeing to the surgery also, you can fall back to serial casting.
As you told in the tardio scale, is there any cutoff difference between R1 and R2? Then we go for the surgical correction or the conservative management of the...
We use the tardio scale when we do not want to do surgery. So we just want to see whether there is only dynamic spasticity, because see, botulinum toxin is an expensive injection. You cannot waste the injection on the patients. A lot of money is being spent by the patient. So we just want to be sure whether the candidate is the right candidate for botulinum toxin or not. So tardio scale we use in the setting of only when we are considering the patient for botulinum toxin, whether we want to know that toxin is going to help the patient or not. If there is a contracture, then we think of, if the child's age is more than 6 years,
So as
we
you
don't,
told sir, the difference between the
R1 and R2, yes.
हाँ sir. If there is less difference, then there is a contracture. If there is specific range difference cutoffs, then
There's no cutoff, there's no such cutoff like anything.
So it depends what you are planning and how you are doing. I think that it's a more of a learning curve. The more you do, the more you learn.
yes, sir.